Okay, everyone, we will go ahead and get started. My name is Regina Jarrett, and I am a health education specialist in the Division of Laboratory Systems, DLS, at CDC. A couple of notes before we dive into this webinar. If you're experiencing any technical issues, feel free to email the OneLab inbox for support at onelab@cdc.gov. If you have questions during this session, enter them in the Q&A section below the Q&A icon. We'll hold a Q&A session at the very end of this presentation where we'll review questions, do our best to answer them. And I've also posted a link to the live caption in the chat. So please keep the caption window open if you use it, in addition to the Teams webinar. Today, we will open with a few words from Victor De Jesus, the Acting Director of the Division of Laboratory Systems at the CDC. Then we'll introduce some of our OneLab resources and today's speaker. We'll also have about a 10-minute Q&A session at the end where we'll review questions and do our best to answer those questions. Today's session will end with a discussion of upcoming network events. And for today's webinar, we will be leaving the chat feature open for your engagement. When using the chat box, please keep the appropriate rules of engagement in mind and feel free to use the chat to connect with others by reacting to what you've heard, sharing experiences, and asking questions to fellow participants. If you have questions for the presenter today, please use the Q&A function, not the chat. Additionally, please engage with respect and professionalism, and any inappropriate language, improper conduct, or discrimination may result in removal from this webinar. Please ensure your comments are relevant to your topic if a moderator gives direction regarding chat behavior, and please comply accordingly. Please notify a moderator if you have experienced any technical difficulties or observe any disruptive behavior. So without further ado, I'll turn it now over to our OneLab Network lead, Alicia Branch.
Thank you so much. I would like to wish our OneLab members a happy Lab Week. And it's my pleasure to introduce Dr. Victor De Jesus, the Acting Director of CDC's Division of Laboratory Systems, who will provide the opening remarks. Over to you, Victor.
Thank you, Alicia. Good day to all of you. My name is Victor De Jesus, and I am the Acting Director of the Division of Laboratory Systems at the Centers for Disease Control and Prevention. It is my pleasure to welcome you to today's OneLab Network event on how clinical standardization programs advance the quality of laboratory testing. While in the US, the CLIA regulations do not specifically address the use of standards, laboratory professionals recognize that there is a role for clinical standardization programs and consensus standards to help them strive for high-quality test systems. CDC's Clinical Standardization Programs mission is to improve the diagnosis, treatment, and prevention of selected diseases by standardizing clinical laboratory measurements. These programs work to create measurement results with the same analytical accuracy and precision to simplify comparison among them. I want to thank our speaker, Dr. Heber Vesper, for delivering today's valuable presentation. I also want to thank the Division of Laboratory Systems staff who made this event possible. Dr. Branch, back to you.
Thank you so much. And thank you again for your warm remarks. Before the main presentation, I'll introduce new OneLab resources and then read the PACE disclaimer. Next slide, please. We're pleased to announce 3 new virtual reality specimen handling scenarios available in OneLab VR and on Reach. These simulations provide users with the opportunity to enter a virtual core laboratory to practice blood, urine, and respiratory specimens without the risk of exposure to infectious substances. Next slide, please. In addition, we're highlighting what's the total testing process video, which provides early career laboratory professionals with an overview of the clinical testing cycle, including the pre-analytical, analytical, and post-analytical phases. Links to both resources have been placed in the chat. Next slide, please. Subject matter experts and presenters wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. I am excited to introduce, next slide, please. Introduce our presenter today, Dr. Hubert Vesper, who is the director of the Clinical Standardization Program here at CDC, where he leads national and international programs and activities to enhance patient care through laboratory standardization and harmonization of clinical tests. Dr. Vesper provides scientific leadership and technical expertise to initiatives focused on standardizing and harmonizing disease biomarker measurements. He currently chairs ISO TC 212 Working Group 2, overseeing the development of ISO standards for reference laboratories and materials. He also is a co-chair of the Partnerships for Accurate Testing of Hormones, better known as PATH, coordinating education efforts among stakeholder organizations to promote quality and clinical testing and standardization. With over 100 publications, including 8 clinical laboratory and practice guidelines and recommendations, Dr. Vesper is a recognized leader in the clinical laboratory test standardization, and he looks forward to presenting on the CDC's Clinical Standardization Program and their impact on improving patient care and laboratory testing. Our speaker for today, Dr. Hubert Vesper. Over to you, Dr. Vesper.
Thank you. Let me share my screen. Okay, can you all see my screen?
We can.
Okay. Well, thank you for the very nice introduction, and also would like to thank the organizers of One Lab for giving me the possibility to talk about CDC's clinical standardization programs. And in my presentation, I will talk about why we conduct these standardization programs, how they relate to proficiency testing, and describe more in detail how we operate these programs. For those not familiar with our programs, our focus is on chronic diseases. And the 5 key areas that are covered by our programs are shown in the slide. So, for example, for over 60 years now, we ensure that blood lipid measurements conducted in the United States are accurate and reliable. And the instruments you use in your laboratory to measure total cholesterol, they're calibrated and verified by our programs. In addition to traditional blood lipids, we also cover lipoproteins such as Lp(a) and apolipoprotein B. The majority of analytes that we address in our programs are hormones like thyroid hormones, parathyroid hormones, and vitamin D for kidney and bone diseases, and steroid hormones for certain cancers and reproductive health. In the area of diabetes, we are a reference laboratory for glucose and support the National Glycohemoglobin Standardization Program for A1C. And this program actually was designed based on our cholesterol program. Our reference laboratories are ISO accredited according to ISO 15495 for clinical calibration laboratories, and our research labs, where we conduct mainly epidemiological research, are CLIA certified. Now, before we start, let's do a poll. Do you think test results with FDA-approved tests and operated in CLIA certified labs are always accurate and comparable? And you have 4 choices to choose from, so feel free to select one. Go ahead. Okay. I hope everybody was able to select an answer for the first question. Do we have a feedback on the results? Yeah, I don't hear anything. Do we get some feedback on the results from the poll?
We did. It's
Yes.
showing on the screen.
Oh,
Yes.
okay. Because I'm presenting, I probably don't see it.
Yeah.
Sure. I can read
Fidel,
it
you
off.
may want to
Yep.
give him read the
Okay.
results for him.
So Hubert, we have 31% that mentioned is highly accurate and comparable. We have 64% indicating that it's somewhat accurate and comparable, and 0% for not confident in test results, and about 6% said they don't know.
Okay, very good. Well, those who voted somewhat accurate would be correct. Now, some of the tests that we use in patient care are accurate and comparable across devices. However, others aren't. And those are the tests that we are particularly interested in our programs. So to further explain this, I choose vitamin D as an example. Professional organizations recommend testing for vitamin D as part of patient assessments. And so vitamin D testing has become a common analyte in clinical laboratories. In this slide, I'd like to share observations we made in the 2018 College of American Pathologists Accuracy-Based Vitamin D Survey. And this is a special survey offered by the CAP. It uses non-modified pooled serum that was prepared in a manner to have characteristics as close as possible to regular patient samples. In addition, this survey has vitamin D target values assigned by the CDC reference laboratory. And in this slide, the target value for the particular sample we will be looking at is indicated in the red line with a line with a value of 57.06 nanomoles per liter. So, oops, I'm sorry about that. The blue bar indicates the highest and lowest value reported by a peer group, and the orange line represents the median of the results reported by that particular peer group. There were 12 peer groups in that particular challenge, and the results of these peer groups are shown here with all tests passing this particular PT challenge. But if you look at the orange bars, 7 out of 12 participants have the majority of results reported in a concentration range that would indicate that this sample, this patient has inadequate vitamin D levels, while the reference values indicate that it actually is adequate. I also like to point out that all peer groups use FDA-approved devices. So being CLIA certified and using FDA-approved devices does not automatically ensure that all the results are accurate and comparable across devices. Or, if you want to look at the other way around, each time we compare a lab result to a general accepted decision point, like in this case, the cut points issued by the National Academy of Medicine or former IOM, measurements need to be consistent across devices. Otherwise, cut points cannot be used appropriately. Also, to put the vitamin D example in a different context, in 2022, CMS spent $257.5 million on 8.8 million vitamin D tests. So vitamin D, in terms of cost, was the 7th highest lab test reimbursed by Medicare Part B. So we really need to make sure that results obtained with these tests are accurate and reliable. I also want to point out that the analytes marked with a star are analytes that are addressed by our standardization programs. Now, there are several hundred tests, in chemistry at least, used in patient care. And while some of these tests are just fine, others are in high need for standardization. And this slide shows some examples from professional organizations pointing out problems with not only vitamin D, but also testosterone, estradiol, thyroid hormones, and Lp(a). And our standardization programs respond to these situations by working with professional societies and the laboratory community to improve the accuracy and reliability of the tests. And now, in general, the majority of requests we actually receive to standardize and improve tests are from professional organizations. And they point out that the high variability among tests either prevents the development of new, better guidelines or hampers the broad implementation of existing guidelines. And before I go into details on how we conduct standardization, I'd like to talk how proficiency testing and standardization activities relate to each other. Now, with the PD for chemistry tests, we have typically 2 to 3 challenges per year, and participants are grouped in peer groups, meaning labs using the same instrumentation, and their results are compared to the results obtained in that peer group. And PT challenges typically cover the whole testing process, from receiving the samples, analyzing them, to reporting the results. And the assumption is that the laboratory or laboratories using the same instrumentation should get the same results. In other words, proficiency testing evaluates the lab using a particular device, not the agreement among peer groups. And the number of labs combined in one peer group can differ from challenge to challenge, and only data from one challenge are used in an evaluation. So by design, proficiency testing programs are typically cross-sectional. On the other hand, CDC standardization programs only assess and evaluate the analytical performance of an assay. And we compare the performance to predefined performance criteria, such as an allowable bias. We don't evaluate per peer group, but we evaluate relative to a methodological reference. Also, we look at performance of each participant over time as part of the evaluation. So by design, standardization programs are typically longitudinal. The key is that PT evaluates the whole testing process and normally evaluates a lab relative to a peer group. And this is because clinical laboratories typically cannot manipulate or modify their instrumentation. And therefore, our standardization programs focus on the part that the lab cannot modify, and proficiency testing providers typically do not evaluate. So our programs make sure that devices are accurate and reliable across peer groups. And with that, PT and standardization programs complement each other. Now, moving on to our standardization programs. In an ideal situation, the laboratory does not need to worry about whether an IVD device is standardized or not. In example, for A1C or total cholesterol, all devices used in the United States are standardized and results are accurate and comparable. However, for the hormones I mentioned earlier, standardized and non-standardized assays are available and being used in patient care, and here it is important to know whether the assay is standardized. And this brings us to the next question: how familiar are you with CDC's clinical standardization programs? And again, you have 4 choices to check, so feel free to make your selections. Do we have some results back?
Yes, we do. So about 45% of the participants on the call are somewhat familiar. They are aware of the concept and their importance, and about 30% are very familiar with our activities or lead standardization efforts in their lab. And about another 25% of them have heard of them or are not very familiar at all.
Okay, very good. Well, those familiar with our work, this will be a refresher. And those not familiar, I will explain our programs and what we do more in detail. So the goal of our standardization programs is to improve patient care by standardizing clinical laboratory measurements. And in other words, we focus on the analytical performance, not the diagnostic performance of the test. And we do this by making measurement results accurate and reliable and traceable to one accuracy basis, and therefore comparable across devices, location, and over time. And it's important to understand that our focus is on the measurement results, not the technologies or procedures. So everybody can use the test it fits best their need. What we care about is really the results that comes out of the test, or that technology. Also, it is important to understand that standardization is an ongoing process, not a single task. Initially, we work on improving the analytical performance, and then we need to make sure we maintain it because equipment and reagents change, and we need to make sure that those changes don't affect the analytical accuracy. Also, to us, a standardized test went through a thorough independent assessment and demonstrated that it meets analytical performance goals. So IVD manufacturers and many laboratories use certified reference materials for calibration and a check on the calibration of the assay. And while we recommend doing that, one has to understand that this action might not be enough to ensure accuracy and comparability across devices. I also want to point out that CDC is not developing analytical performance goals. This is typically done by the laboratory and medical communities. We help and assist with data and technical expertise, but the actually goals are developed by these communities. And what we do is we adopt then these analytical performance goals in our programs. And for standardization programs to be successful and useful to patient care and public health, we need to conduct a range of activities that can be divided in 3 categories that are shown here. First, we need to establish the tools needed for standardization. This is mainly the development of reference methods and reference materials. And then in the second part, we use these methods and materials and work with IVD manufacturers, laboratories, and proficiency testing providers to improve the analytical performance of the assays. And in the last step, we facilitate the integration of standardized assays in patient care. And an example, by developing new reference intervals based on standardized assays, because when we recalibrate assays, the reference intervals need to be adjusted accordingly. So I go over each category in the next slides. In our laboratory, we have reference methods established or in development for the analytes listed in the first bullet here in the slide. In terms of reference materials, we create mainly single donor sera that are not modified and that were produced in a manner that makes them as close as possible to a regular patient sample. We also support the production of traditional reference materials that are available from NIST and other organizations. Those are pooled serum samples obtained from multiple donors and are available typically at 2 or 3 different concentrations. And to conduct assessments of analytic performance in a consistent and transparent manner, we need protocols. And our protocols are based on CLSI protocols such as CLSI EP9 for bias assessment, and we provide additional information on logistics and other details to ensure a consistent execution of these protocols. The reference methods that we operate in our laboratory are optimized for assay calibration and to verify the accuracy of IVD devices. In other words, these methods are not intended for regular patient testing. To properly assess the accuracy of a device or calibrate a device properly, our methods need to be highly accurate and precise. And this is illustrated in the table here, where we list our performance requirements for our reference methods. And for orientation, we also provide performance requirements for routine tests as stated by CMS. So, for example, for cholesterol, the maximum allowable bias and imprecision for our reference methods is 1%. In this context, I would also like to point out that tests in red color, for these tests, we are the only reference laboratory in the United States that continuously operates these reference methods. When it comes to actually improving the analytic performance, we use a 3-step approach. In the first step, we work with the lab or manufacturer and assess the analytical performance by doing basically method comparison studies. And here we provide serum samples with values assigned by our reference methods. We typically provide 40 samples, so participants can use USI EP9. However, we can really provide any number of samples, and we have sets of 120 different samples for more detailed assessments. To claim an essay to be standardized by our program, however, participants need to enroll in our certification programs. Here, participants receive blinded samples that they analyze and report back to us. We analyze the results and compare them to analytical performance goals, and those who meet those goals will receive formal certificates and are considered standardized. The certificate is valid for only a certain time and needs to be renewed. Since certification is typically done at the manufacturer level, we monitor the analytical performance at the laboratory or end user level, if you will. And in this third step, we make sure that improvements we made at the manufacturer actually reaches the end user. And these monitoring activities are done in our CDC accuracy-based monitoring programs and by collaborating with PT providers on their accuracy-based PT programs. Earlier, I talked about a thorough and independent assessment, and this slides provide some details what we mean by that. In our certification program, we use 40 single donor samples that cover the analytical measurement range. By using 40 samples, we can also distinguish between calibration bias and bias caused by non-specificity or other factors. We ask participants to provide replicate measurements so we can assess the imprecision, and we perform quarterly challenges where we send out 10 samples per quarter, and then we combine the data from 4 quarters to make a final assessment. And by doing so, we also obtain information about the performance over time. Also, I'd like to point out that we customize the samples we provide, meaning each participant gets a different set of samples, and we make sure the samples are all within the analytical measurement range of the assay. And of course, we also conduct a detailed data analysis, trying to eliminate possible clerical errors to the extent that we can identify them. We provide, in our certification report, we provide very detailed information about the analytical performance of the assay. And this slide just shows graphs from one page of the report. This would be an example of a certification report from a testosterone participant. The graph that I'm showing here is a bias plot with the x-axis showing the reference values of all the 40 samples that we provide. Each circle represents one sample or the mean of 4 replicate measurements. And the y-axis is the difference between the reported value and the reference value as bias in %. Now, when we look at the average bias across all 40 samples and the bias distribution at the higher concentrations, when we see something like that, we conclude that this assay is very well calibrated. However, when we look at the lower concentrations, we see a much higher scatter of measurement bias. And typically, in situations like these, the assay has a problem with analytical selectivity or specificity and analyte recovery. So for the participant, this information is very helpful because they know in order to improve their assay, they don't need to focus on fine-tuning the calibration, but they really need to focus on minimizing the non-specificity of the assay. And while we provide very detailed information to our participants, we also provide a summary of our findings on our website. And this table shown here is just a snapshot of one of the tables we have on our website. This is for vitamin D. Now, being listed on our website means that the assay meets the analytical performance criteria. And for vitamin D, that would be a mean bias across 40 samples of plus minus 5% and an imprecision of less than 10%. And in addition to providing information about the assay itself, we also provide information about the concentration range we tested and information about the individual sample pass rate. Now, the individual sample pass rate can be used as an indicator of method selectivity or analytical selectivity. And what it basically is it is the proportion of individual samples meeting the plus minus 5% bias criterion. So in this case, 90% of the 40 samples investigated meet the plus minus 5% bias criterion. Now, on our website, we have about 48 LDTs and immunoassays listed. And when we look at the median sample pass rate, about 32%, the average sample pass rate is 32% for immunoassays and 65% for mass spectrometry assays. And what I want to bring across here is, even though assays are well calibrated, we still have some work to do in this particular case to improve the individual sample variability that we observe with, especially with vitamin D assays. Now, in this slide, the bias plots from all participants, certified and non-certified, the data that we collected over the past 10 or so years are shown, and each dot basically represents the mean of 4 replicate measurements. And the point I want to make here is that every analyte is different and has different challenges. And so we really need to customize our programs in order to not only improve the calibration bias, but also to improve the scatter that we see here now with the individual samples, because ultimately we want to have all analytes to look like total cholesterol. Earlier, I mentioned that standardization is a process where we not only improve, but also maintain accurate and comparable measurements. The figure on the left shows observations we made in our accuracy-based lipid program. Here, we are looking at about 50 laboratories. They all use the same assay. And at the beginning, the first couple of years, this assay was nice and accurate. And then all of a sudden, the accuracy was drifting. Now, in a patient care setting, this small bias might not be of concern. However, if the trend continues, it might become a problem. So we informed the manufacturer who corrected the situation, and the results and the measurement bias is back on track. And so because our reference methods are so accurate and precise, we were able to detect these subtle changes early. And this is needed because our goal with the monitoring programs is to make sure that we can detect and address possible trends early before they become a problem in patient care. Now, the figure on the right shows data that we collected from a laboratory-developed test. Again, at the beginning, measurements where the bias was nice and everything was within the limits, but then all of a sudden the analytic performance deteriorated, and upon further investigation, it turned out to be an operator problem. The problem was resolved, the assay was back on track, but then all of a sudden we saw again a more systematic shift in measurement bias, which turned out to be a calibration issue. Now, by providing this kind of information to participants in this particular situation, the laboratory was able to improve the quality management system and now provides better training to lab staff and implement more strict calibrator batch comparisons before new batches are being used. In terms of integrating standardization in patient care and public health, one main activity that we are conducting is developing reference intervals using standardized assays. And the projects that are currently ongoing are development of reference intervals for estradiol in postmenopausal women and for testosterone in all women. And we also work on improving pediatric reference intervals in general. Another area that is quickly developing is with electronic health records. And here, with the broad implementation of electronic health records that contain lab results, comparability across peer groups, or interoperability of data becomes more important. Because currently data from different labs and healthcare systems are all combined in big data hubs, and people are now starting conducting research using these lab data stored in these data hubs. Now, to make correct interpretation of these data, standardization now becomes even more important. And we work with stakeholders to create awareness about the importance of standardization in this area. Testosterone is a nice example how standardization in patient care and research help to develop and effectively implement new practice guidelines. On the top of this graph, we have a regular patient care setting where a patient visits the doctor, a test is being done, the test result is then being compared to a cutoff value from a practice guidelines, and based on that comparison, an action is being initiated. The guideline itself is based on research studies where testing was also laboratory testing was also conducted. And so in our standardization programs, we not only improve the comparability and accuracy of tests conducted in patient care, but also we work with principal investigators of large clinical trials to make sure the testing conducted in these trials is accurate and comparable. And then by having these data, in this case, the Endocrine Society developed evidence-based clinical guidelines with cutoff values based on standardized assays. And because of we have cutoff values based on standardized assays, as well as standardized assays in patient care, clinical decision-making, or in other words, the implementation of these practice guidelines is much more effective, to a point that payers now promote the use of these guidelines in conjunction with standardized assays. Changing gears a little bit. When we monitoring the health of the US population to evaluate public health activities, standardization is very important. The graph here shows the prevalence of high cholesterol and low HDL cholesterol in the US population over a period of 20 years. And these data are obtained in ENHANCE using 5 different assays. And we only can look at these trends with confidence because all the assays used over the past 20 years were assessed and certified by our programs. And the laboratories conducting the measurements successfully participated in our accuracy-based monitoring programs. So therefore, our programs are not only beneficial in healthcare settings, but also in public health, especially when it comes to assessing long-term trends in populations. Coming back to proficiency testing, at the beginning I showed you some PT data on vitamin D at the time when the vitamin D standardization program just started. These are now data, proficiency testing data on testosterone at the time when we just started with our testosterone standardization program. And shown here is the bias distribution of 5 peer groups with the instrumentation used in peer group 4 being standardized at that point in time. And the figure shows that standardized assays are more accurate than non-standardized assays. But the important message here is to understand that standardized and non-standardized assays are used in patient care right now without distinction. And this is because our program is voluntary. So people are not required to participate. They typically participate because quality of testing and accuracy is important to them. For the laboratory, it is important to understand that when we have standardized and non-standardized assays available, that when you use common established cutoff values. You need to know how accurate your assay is in order to appropriately apply those cutoff values stated in clinical practice guidelines. Also, I'd like to mention that the data that we produce are not only used by assay manufacturers and laboratories, but also by FDA and CMS. They use our data to inform decision-making. Also, medical organizations and healthcare payers see the benefits of standardized tests and recommend using those tests in their guidelines and policies. Now, what can the laboratory do to ensure that their tests are standardized? Well, first you can check our website to find out if your assay is standardized, and we update our website every quarter. You can also check the accuracy of your assays by using reference materials or the reference services offered by our programs. Or you can participate in accuracy-based proficiency testing or monitoring programs. And those programs not only provide you with information on how your test is performing, but also helps us with detecting and addressing concerning trends early. So in summary, CDC clinical standardization programs ensure that measurement results are sufficiently accurate and reliable across devices and over time. Our programs are complementary to PT EQA programs because we focus on analytical performance across peer groups and improve parameters such as device calibration that typically cannot be performed by the laboratory. Participation in our program is voluntary, and as a result, we have standardized, non-standardized assays available in patient care. And it is important to know if an assay is standardized, especially when tests are compared to clinical decision points mentioned in guidelines. And with that, I'm at the end of my little presentation. I'd like to thank you all for listening. And of course, I'm here to answer any questions you may have. Thank you.
Okay, we'll take a few minutes to answer as many questions as possible. If we're unable to answer your question today, we'll do our best to respond by email. And if you have questions after today, please feel free to email them to the OneLab inbox at onelab@cdc.gov. Okay, let's see. Now, okay. So I'll kick off this first question. I already participate in PT and EQA. Do I also need to participate in the Clinical Standardization Program?
If you have the regular in vitro diagnostic device, the participation is normally done by the manufacturer. So in you as a laboratory, you don't need to participate in our certification program. Please keep in mind when you participate in a regular EQA program, many times the samples in these EQA programs are highly modified. And so while you can compare your results within your peer group, you don't have good information about how accurate your assay is compared to an assay from a different manufacturer. For that, we recommend either participating in our accuracy-based monitoring programs or the accuracy-based proficiency testing programs that are available by PT providers.
Okay. The next one is, what steps should the laboratory take to evaluate and ensure the analytical accuracy of their test?
Well, you need to do your regular testing for clear purposes, and with either calibration verification, for example, materials that are provided by EQA providers, or reference materials that you can purchase commercially. If you cannot find a material, or the material you feel is not suitable for your particular assay, you can always send us an email or check with us, contact us, so we can see whether we can help you with the accuracy assessment of your essay.
Okay. Are certain technologies better than others?
Sometimes, what we observed is that I mentioned the example with vitamin D, where the sample-specific pass rate is much lower for immunoassays than for mass spectrometry assays, indicating that mass spectrometry assays might be more specific. One thing to keep in mind is that we saw a lot of improvements with immunoassays over the years. And so a technology that might not be optimal right now might become better with the second or third generation of the assay. So it's always good to look at the latest information that is available in terms of measurement accuracy. And it also depends on the intended use of your assay. And I know that some laboratories use, for example, immunoassays for measurements of testosterone in men, and mass spectrometry assays for measurements of testosterone in women. So it really depends on the application. But we do see mass spectrometry-based assays, for example, also failing our programs. So a certain technology is not a guarantee for high-quality testing.
And one last question. If someone was interested in participating in the CDC Clinical Standardization Program, how would they go about contacting you or being a part of the program?
We do have the easiest way to do is to send us an email at standardization@cdc.gov. And the email is also shown here on my last slide. We monitor this email on a daily basis, and we will reach out to you to find out what you need and how we can help.
Thank you so much for joining us today, and we're sure to contact you again to present on another One Lab event.
Thank you. Pleasure to be here. Thank you.
Next slide, please, Jessica. Just a reminder, today's event is eligible for 1 hour of PACE credit. However, our PACE credit is temporarily unavailable. So our efforts are underway to reinstate PACE, and once it is reinstated, our eligible participants, those who have joined today, will receive the instructions on how to obtain their certificate. Next slide. We'd like to briefly highlight the next One Lab Network event, which will occur on June 10th at 12 p.m. It's entitled Overview of Testing Personnel Qualification in Moderate and High Complexity Testing, and it will be presented by CMS. Registration instructions and additional event details will be shared soon. Next slide, please. As a reminder, the slides and audio recording from today's event will be posted to our website within 2 weeks from today's event. And finally, I encourage you all to use the One Lab inbox to share your training needs and your feedback. We actually use your input to select event topics and to better understand the community's needs. And also, if you're interested in serving as a pilot tester for our One Lab Reach e-learning courses, the One Lab email address is also posted in the chat for easy access. And I would like to say thank you. Again, have a great laboratory week, and have a great rest of your day.